Okay. Well, first I'd like to say thanks for coming. It's not very often that we get to preach our gospel to everyone in a big setting like this, and so I'm very thankful to be here, and hopefully you'll get some pointers and tips that may help you, as well as just some better general understanding of what hypertension is. So as Daryl mentioned, I'm actually he didn't mention. Hey, I thought he would, but he didn't mention. I need to add to what he said. No, I played on the junior varsity league for NEA Baptist for a long time, and then I eventually got promoted to the big leagues, I guess, so I'm happy to be here. He was joking that I signed early, and I did come on early, but I had already finished some training. So it wasn't right out of college, but I'm a nephrologist, so I'm a kidney doctor, and you may not know this, but kidney doctors do a lot with high blood pressure, and so when I started my practice, I started seeing more and more patients with hypertension, and then I decided that this is a big percentage of my clinic, so I went on further and got a specialty degree in hypertension as well, and so I'm one of the only ones in the state with this degree, and so maybe I have a little bit of expertise, even though I'm not all that old, but any talk about high blood pressure has to start with the definition of hypertension. And so this is a definition that was given by the American Society of Hypertension Working Group, a bunch of smarter doctors than myself who came up with this definition. And it basically reads that hypertension is a progressive cardiovascular syndrome arising from complex interrelated etiologies. Early markers of the syndrome are often present before blood pressure elevation is sustained. Therefore, hypertension cannot be classified solely by discrete blood pressure thresholds. Progression is strongly associated with functional and structural cardiac and vascular abnormalities that damage the heart, brain, vasculature, and other organs and lead to premature morbidity and death. So that is hypertension. So you may be asking yourself, where are the numbers? There are no numbers here. And what we're starting to realize and figure out is that hypertension can be classified solely by can be classified other than just by numbers. And so some of the things we've noted here I put in blue, but it's high blood pressure is progressive. It continues. It's complex. It's present. Early markers of the disease are present even before your blood pressure is up, and its progression is strongly associated with suffering and death. Defining hypertension, like age, high blood pressure is distributed throughout a population. So any definition of hypertension is purely arbitrarily. Does that make sense? So if someone was to say, how would you define age? What number is old? That's relative, right? Some people would say old is 10 years older than I am. And as far as blood pressure, someone might say high blood pressure is when I feel poorly. So trying to get an actual number is difficult. There are several approaches to define hypertension by numbers. One of these approaches is defining hypertension by morbidity and mortality. So what you could do is you could look at a large population of people, and for every person at a certain age, at a certain blood pressure, what is the risk of death, either from stroke or from heart attack or heart disease. And they've done this. They've looked at over 1 million people, and they've looked at the risk of death for heart disease. And so this slide here shows you that as your blood pressure increases, let's say, this is a 50-year-old, from 120 to 140, your risk of death increases by double. It doubles. So it goes from 4% to 8%. That's your risk of death from heart disease. Okay. There's one other thing to point out by this, and that is that the risk of death is more strongly associated with age instead of blood pressure. So if you look at a 50-year-old with a blood pressure of 140, the risk of death from heart disease is about 8%. But if you jump up to 60, it's about 16%. So that's really makes everybody feel better today. But as your blood pressure increases over 120 over 80, every time it goes 20 on the top or 10 on the bottom, your risk of mortality doubles. Okay? So by looking at this in a large population study, they were able to come up with a definition of prehypertension. So this is high blood pressure before it's high blood pressure. Okay? It's greater than 120 over 80. Okay? So that's one of the things that people have looked at. You have to be cautious when you look at this, and I'll get in this a little bit more in just a second. You can also define blood pressure by statistics, okay? And this is how we do this in children. If you're greater than the 95th percentile, then you have high blood pressure. If you're 90 to 95, you have prehypertension. And if you're less than 90% of the rest of your peers, then you're normal, okay? So you could define it like that. You can also define high blood pressure by the threshold of therapeutic benefit. So what this means is they do a bunch of studies. They take a group of people with this particular blood pressure, and they say, if we get to a certain number, will we reduce our risk of death or stroke or whatever they're looking at? And so on the graph here, there are actually several studies on the columns, and the starting blood pressure was 150 in this study, and they got it to 146, and this study 150, 138. Well, anyway, if they prove benefit, then it's blue. Okay, so when they decreased it from 149 to 138, there was some benefit in this study. And so they said, okay, if we get less than 140, there's benefit. And so the Joint National Commission took all of this data, and they looked at more studies than listed here, and they said, okay, if your blood pressure is less than 140, then we can prove there's some benefit to it. And so that number has been declared the threshold of therapeutic benefit. Does that make sense? No. Some shaking no, some shaking yes. What it means is that if you're over that number, you're at higher risk. If you're less than that number, maybe it's better for you. So they say if you're that number or under, you're good. Does that make sense? Okay, moving on. So, by taking these studies, they found that you can define high blood pressure in several different categories. And one is normal, so they figured that if you're less than 120 over 80, consistently, there's nothing to worry about. That's pretty good. If you're not 120, but you're not 140, you're in the middle, then that's sort of considered pre-hypertension. Okay, that's that where your risk is a little bit higher, but maybe not so bad. And then definitive hypertension right now is greater than 140 on the top or greater than 90 on the bottom. Okay? And then they even went so far to say there is another stage where it's hypertension stage 2 when it's greater than 160 on the top or greater than 100 on the bottom. Okay. So what are we actually measuring? When we're measuring that top number and that bottom number, what are we measuring? What we're measuring on the top is the systolic blood pressure. The systolic blood pressure is the pressure that is exerted on the blood vessels by the heart. Okay, so when the heart squeezes, it pumps blood out of the heart into the blood vessels. Well, that pressure causes the blood vessels to stretch. Okay, and so the blood pressure, when the blood pressure is the highest, the blood vessels are maximally stretched out. Okay, and then the heart relaxes. And so there's no more pressure by the heart. So where does the bottom number come from? The bottom number is when the heart is resting. And when the heart is resting, the pressure comes from the blood vessels, not the heart. So the blood vessels stretched, and then when the heart is resting, the blood vessels recoil and put pressure on themselves. Does that make sense? So when the heart pumps, it's systolic pressure, stretch on the blood vessels. When the heart relaxes, it's the elastic recoil of the blood vessels that causes the pressure. Okay, the top number is the systolic, the bottom number is the diastolic. How is this measured? How is it obtained? We put a cuff on your arm and we blow it up. And we blow it up tight and to where there's no more blood flow through that arm. Okay, sounds very fun. And when there is no more blood flow through that arm, when you put your stethoscope over the brachial artery, you do not hear anything, okay, because there's no blood flow. So then you start letting the air out of that cuff, and eventually you'll get to the point where blood will be allowed to start passing through that artery, okay? When it passes through the artery and it's partially collapsed, it makes a swishing sound, okay, because there's turbulence in that vessel. So you hear the swishing, and the first time you hear that swishing, that's the top number. That's the highest pressure. And then you keep letting air out of the blood, out of the sphygmomanometer, and then when it's completely gone, or when the pressure in the body can overcome the pressure in the cuff, then the artery is wide open, and that is your lowest pressure, okay? Does that make sense? Sort of. Okay. I won't belabor the point, guys. What causes high blood pressure? High blood pressure is caused by several different systems. One is the brain. The brain creates sympathetic nervous activity that controls the blood vessels and also regulates the kidney in some degree. Then you have the kidney at the bottom there, and you have the heart, and you have receptors in the vasculature of the heart and the blood vessels, and then you also have the arteries and the veins. You also have genetics. So your mom and your dad have something to do with high blood pressure, but they probably get blamed for more than they really should be, okay? It's only about 30% at maximum. My mom's here, by the way, so I'm sorry. Let's see. Okay, so what happens as you age? As you age, your blood vessels get stiffer, and that's normal. That's called arteriolosclerosis. That's normal. But when that happens, the blood vessel cannot relax as easily, okay? And so when that heart beats, it cannot relax as well, and so there's a higher pressure when the heart beats, okay? There's not as much give. And on the flip side of that, as you age, your bottom number gets usually some lower. So most people that are of the age of 70 or getting a little bit older than that, they usually have a pretty high top number if they have high blood pressure, but the bottom number is always pretty good, and that's pretty common. So age has an effect on your blood pressure. One thing to note is that the prevalence of high blood pressure is increasing in our country. In 1940, about 11% had high blood pressure, adults. Today, somewhere around 30%, slightly over 30%. Okay, there are also groups that are more affected than others. So one group that is more affected, as I mentioned, is the elderly. I wouldn't say 60 elderly, but those 60 and older, 65% have high blood pressure. 1/3 of Americans have high blood pressure, to say it another way. And if this continues, there will be about 100 million Americans that have high blood pressure by about 2030. And one thing to note is that some ethnicities are more likely to have hypertension, especially African Americans. Somewhere in the order of 40 to 45% of African Americans have high blood pressure. One thing to note is that women and men are equal in some things, and blood pressure is one of them, okay? And so they all each have blood hypertension about 30%. Okay, so being a woman or a man doesn't help you much. Okay, so far what we've done is we've defined hypertension, we've discussed how we measure blood pressure, and then we've examined some causes. And so the question is, should we treat it? Well, that's a silly question, huh? So one thing to note is that most people used to not think much about hypertension. It used to not really be in the forefront of American thought, for sure. And it really, even some experts would have argued that blood pressure is normal. Any blood pressure is normal, and you shouldn't mess with it. It really wasn't until we had one of our beloved presidents die of high blood pressure that it really became something that we thought of as a bad deal. When FDR died of a brain hemorrhage from high blood pressure, then people started thinking about it. And his blood pressure was somewhere around 300 over 190, close to when he died. And he had a doctor with him all the time. The doctor traveled. The doctor wrote a diary, but they couldn't really do anything about it. There's not much they could give him. And so Congress pressured Truman to set up the National Heart Institute, and that was begun in 1948, and that sort of started the era of hypertension research. So, of course, control is necessary. The reason it's necessary is the effects that it can cause on certain organs. It can cause heart failure. It can cause brain damage and ischemic brain injury and stroke. It can cause blindness. It can cause your vessels to become diseased and hardened. And it can cause your kidneys to fail and other organs as well. One thing to note that's really quite of interest is that how many strokes we could reduce just if we controlled blood pressure alone. And this was looked at in 2000, and they decided that you could probably reduce about 400,000 strokes in the United States if you could just control blood pressure. Now, we spend a lot of time worrying about atrial fibrillation and the stroke risk from atrial fibrillation. People are on Coumadin and blood thinners, and they go to the doctor once a month and get their blood level checked and everything. If we could cure atrial fibrillation, though, it only amounts to about 75,000 strokes a year, just a fraction of what high blood pressure causes. So, of course, we can improve. There is room for improvement. And one thing we've noted is that the interplay among other diseases makes high blood pressure so bad. Most people with high blood pressure also have other diseases, such as diabetes and kidney disease and heart failure. And so these high blood pressure often accelerates these diseases and the effects of these diseases. The other thing to note is just knowing about it. You just coming and being aware of it is not quite enough, because most people are aware of high blood pressure or that they have it, but only a half of them have their condition controlled, and then also a quarter of those people with high blood pressure don't really regularly take their medicines. So what are some things that you can do to help your blood pressure? And this is actually from the Joint National Commission pamphlet that they hand out, and this is what they've come up with by looking at studies. For you, what can help you, one is weight reduction if you are overweight. Obviously, if you're not overweight, losing more is probably not going to help. But if you are overweight, for every 2 pounds that you lose, you drop about 1 point on your top number. Okay? So every 1 kilogram, you drop a point. So if you lost 20 pounds, you're dropping about 10. That's about as good as 1 medication. Okay? So something to think about. The other thing is the DASH eating plan. This is the only diet that's been proven or actually studied to reduce blood pressure. And if you can enrich your diet with fruits and vegetables and low-fat dairy, a lot of people, if they don't already have a good diet, can drop their pressure as much as 14 points. Okay? And then another thing that is important is sodium restriction. If you can drop your sodium to about 6 grams, you can drop your blood pressure about 6 to 8 points. And then physical activity is another thing. If you can briskly walk or do some sort of aerobic activity 30 minutes a day, once that becomes easy for you, you usually have a sustained reduction of about 10. So that's about another medication. And then, obviously, if you drink a lot of alcohol, that can raise your blood pressure. But drinking some alcohol may have some benefit for your heart, but in moderation. So maximum 2 beers or 2 wine for a man and 1 for a woman. And I'm talking about the kind they would give you at a restaurant, which is not much. Okay. What else can you do? You can check your blood pressure regularly. You can know what it is even before you go to your doctor. You can take your medications. You can come to your doctor visits. And you can report medication changes to your doctor. If you go to someone else and they tell you to stop it, or if it doesn't work out for you and you stop it on your own, let them know. They might can try something else instead of waiting 3 months to change it. Okay? And adjust your diet and habits. So one thing is the DASH diet. I already briefly mentioned it. You can Google DASH diet and it's just flooded. I mean, you'll get millions of hits. But the DASH diet is mostly fruits and vegetables, grains, and less sweets and nuts and things like that. And also less salt. You can even find free DASH cookbooks online, PDF files and things. So no talk about high blood pressure is complete without talking about salt. Salt is a good thing. Even God likes salt. You must put your salt on your grain offerings. Salt stands for your agreement with God that will last forever. Do not leave it out of your grain offerings. You must add salt. Leviticus. Tasteless food is not eaten without salt. There's no flavor in the white of an egg. Wow, that hurts. You are the salt of the earth. Nothing. If you lose your salt, it cannot be made salty again. The last one I love. Salt is good, but if salt loses its salty taste, you cannot make it salty. So be full of salt. And have peace with each other. So I guess that means eat a barbecue together and be peaceful. Okay. Salt restriction is important. The average American diet is about 9 grams of salt. If we can drop it to 6 grams, you can lower your blood pressure. If you can drop it to 3 grams, you can lower it slightly more. You can usually get to about 6 grams of salt a day just by avoiding adding salt to things. The shaker is not your friend. And by avoiding processed meats and hidden places for salt, such as frozen food, sodas, canned soups, and you can get there. So, salt restriction was looked at in 1968 by the New England Journal of Medicine. And they looked at two islands. I can't hardly say them, Rarotonga and Puka Puka. These are atoll islands in the Cook Islands. They're in the French Polynesian. And it looks like nobody there should ever have high blood pressure. What they looked at, though, is one thing, and that is that Rarotonga, no one works at McDonald's here, do they? Okay, good. Rarotonga is more civilized, larger population. It's the largest of these Cook Islands, and they have more access to salt. Puka Puka, I like saying that, is, I'm probably butchering it. Is anyone here from French Polynesia? Good. Okay. Puka Puka is about 1,000 miles away from Rarotonga, and you can only get there by the Rarotonga Airlines, and maybe by boat. But anyway, they don't have as much salt in their diet, and so someone was astute enough to look at this, and what they found out, there we go, is the Rarotongans had a higher blood pressure than the Puka Pukans. I'll stop saying this eventually. And so not only did they have a higher blood pressure at any age, but as they got older, their blood pressure got worse. And so what they found out and what they've decided is that salt has something to do with raising your blood pressure, but it also has something to do with age progression of blood pressure. And so that's a pretty convincing argument. What else can you do? You can stop smoking, but there's not a huge role that smoking causes high blood pressure. Although they do say before you get your blood pressure taken, don't smoke for an hour before. Blood pressure has a lot to do with your blood vessels and damaging of your blood vessels. I mean, smoking does, sorry. And so, you shouldn't smoke anyway. But the actual contribution to high blood pressure is kind of undecided. Caffeine, coffee is not all that bad. It raises it about 1 point if you're just sipping it all day long, like I do. But if you take the tablets or maybe those energy drinks and things like that, it probably raises it on average about 4 points. So it is a substantial increase taking enough of it. You want to avoid cold medicines if you got heart disease and things like Sudafed will significantly raise your blood pressure. And then stress. There is some evidence that stress has something to do with high blood pressure, although the actual contribution is sort of undetermined. What they have found out that meditation will lower your blood pressure. Prayer will lower your blood pressure. And people who reported having a stressful job, just by reporting that, their blood pressure seemed to be higher than other people who did not report that. So how is NEA Baptist Clinic attacking high blood pressure? There's a few things we're doing that are kind of new. One is the patient awareness. We're trying to do things like this, and we're trying to engage people to be a part of this campaign called Million Hearts Campaign, which is more about patient-centered awareness of blood pressure and taking control of it yourself and playing a more active role. Another thing is a provider-centered campaign, which is sponsored by the American Medical Group Association. Measure Up, Pressure Down is the name of the campaign. We'll talk more about that in just a minute. And Specialty Hypertension Clinic is another thing we're doing, which is I'm integral. Actually, I'm the only one right now. Hope to get some more. So patient awareness, Million Hearts, you can sign up for that online yourself. And then the AMGA measure up, pressure down. AMGA, just a short word about that. It represents medical groups and health systems providing networking, political advocacy, educational resources, etc. The AMGA represents about 130,000 physicians in the U.S. That are caring for about 120 million Americans. So that's about a third of the U.S. population. And a lot of the big name clinics, I would say including ours, but I wouldn't consider us that great, like the Cleveland Clinic or anything yet. Stay tuned. Okay. Health professional centered initiative. It's encouraging more awareness among our own providers. That's what the Measure Up, Pressure Down campaign is really starting at. And it's also utilizing proven techniques and systems to control your blood pressure. So we're advocating using the things that we know, using the prior studies and the Joint National Commission recommendations of certain types of medications in combination to actually control blood pressure, sort of re-educating our providers and our nurses. And we're hoping to fight clinical inertia. The way we're doing that is hoping to see patients sooner. One of the problems is you go to your doctor and you have high blood pressure, you get a medicine. And then you take that medicine for a month and it didn't sit well with you and you stopped it. But your appointment's not till 2 months later. And so you go another 3 months or so with uncontrolled high blood pressure. Then you come back and we try a new medicine. And so what we're trying to do is bring people back sooner to see either the doctor or a nurse practitioner and to get that blood pressure under control in a short amount of time, rapid titration of medications, and then get you stable and on your way, you know. Our goal is to have 80% of the people in our clinic who have high blood pressure controlled. And we are setting that goal for 2016. That's actually the AMGA's goal. So how are we going to do that? This doesn't project all that well, but there are several different things we're doing and attacking, and I just mentioned a few of them. One thing we're doing is we're checking a blood pressure at every visit. We're trying to do that. And sometimes you go to someone who may not check blood pressure. You know, you may go to a foot doctor or something. They may not check blood pressure, but we're trying to get everybody to check it, just so we have more readings, more information to go by. Okay? Okay. The measurement of blood pressure is likely the clinical procedure of greatest importance that is performed in the sloppiest of manners. And so one thing that we're doing is training our nurses and people how to do it correctly. We're standardizing our equipment, we're calibrating our equipment, and we're encouraging blood pressures checks. I'm involved with this hypertension clinic. We accept referrals for difficult to control high blood pressure patients. These are usually people that are on 3 or more drugs and not controlled. And every once in a while, we get a patient who's maybe on one drug, but every drug they've ever tried gives them some sort of problem. And so intolerance to many medications, we might look at that. If they're less than 30 years of age, it's a good time to come and see a hypertension specialist to make sure there's nothing else going on other than just pure hypertension. And some of the things that I've done just in the last year of having this clinic is we've diagnosed some things that were treatable causes of high blood pressure. And so 6 people have had renal artery stents. We've had one person have their adrenal gland taken out. We've had numerous people diagnosed with sleep apnea on CPAP machines. We've a young lady who was on oral contraceptives, and that was the cause of her blood pressure, and we took her off, and it's fine. One person had migraines, just uncontrolled migraines, and they thought it was the other way around, the blood pressure causing the migraines. Actually, the migraines causing the blood pressure, and so we treated the migraines and got that fixed. And then we see a lot of people with anxiety, and I don't really like this disease, but it's present. And so, we get them referred to the right people, or we try to treat it. So we do appropriate workup. We do rapid titration of the medicines, and then we bring them back to their primary care physician to manage the rest of it. That's all I have today, unless you guys want me to elaborate. I can talk all day. So, any questions? Anybody? You want to sleep on it? I won't be here tomorrow. Okay.
20 years from now, how will they treat high blood pressure?
That's an excellent question. I think that we're not too far away from, well, first of all, let me say that medications will probably always have a role. I mean, there will probably always be medications. I took out some slides. I didn't want to bore you guys to death, but some slides of where different medications act at different places and how complex the disease of hypertension is, because it's so interrelated to many different organ systems. But there will always be a place for medications targeting different organ systems in the control of blood pressure. But the new thing coming out, and probably within the next 5 years, we'll be doing procedures to control high blood pressure. One of them is called Renal Artery Denervation, and what they do is they stick a catheter in your aorta, and they go to your renal artery, and they ablate the nerves around the renal arteries, and people are getting about a 30-point drop in their blood pressure, sustained up to 2 years, maybe longer. And so looking at procedures to do that, they're also doing where they have implantable devices they put on people's carotids. That is one of your arteries in your neck. But what they do is it controls and signals that cause your blood vessels to constrict. And so baroreceptor, implantable devices, renal artery denervation are things that are coming out probably the next 5 to 10 years. So there are going to be non-medical ways, or should I say surgical ways, to treat blood pressure in the future. Years ago, they used to take out people's adrenal glands and kidneys and things like that, and cut nerves, and we're getting a lot more sophisticated now. So. The question is there anything that can be done to make the arteries more pliable or flexible? I think, although it's a little bit presumptive, that salt intake and lower blood pressure for longer periods of time, like getting your blood pressure controlled at a younger age, probably has something to do with it. But there is a natural age progression of the arteries that causes sclerosis or hardening of the arteries. And that's going to happen no matter what, unless you're Ponce de Leon or somebody. He's laughing. I got one person that likes my jokes. All right. Yes, go ahead. Mm-hmm. 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 So the question is, are there things that will help the top number even if the bottom number is low? You should treat the higher number, because one of the condition you're describing is called isolated systolic hypertension, which means only the top number is high. Okay? And these type of people have a wide pulse pressure. What this means is there's a big difference between the top and the bottom number. This puts people more at risk for strokes. Okay? It's much more dangerous than having them both elevated some, okay? What you're doing is you're having a high force, and then it relaxes in a high force, and so you can imagine beating on the door for years and years. That's not good. How do you treat isolated systolic hypertension? One of the best ways, if you can tolerate it and not have symptoms of low blood pressure or dizziness, is a diuretic. That's going to treat that top number, okay, more than the bottom number. There are some valvular abnormalities, so conditions of the heart, which are going to have that sort of thing, and it's going to be really hard to treat without some sort of intervention, okay? Part of that isolated systolic hypertension is natural, okay? Like I said, as the arteries get stiffer, the top number goes higher and the bottom number goes down. So most people, as they age, have that exact condition, okay? There's not a drug per se that targets just one, but the most effective as you age and for that top number is diuretics. A lot of people don't like peeing all the time. It's true. They don't take their medicine on the day they come to the doctor because they don't want to run to the bathroom. Then they can't give me a urine sample when I need one. All right, what else you got? Anything? Okay, one more. Go ahead. Yeah. So you said what's going on when that happens? So what's going on when you're on several medications or a lot of medication and your blood pressure is still high? So if have that person call me. No, exactly what's happening is that is one thing is if you've had high blood pressure a long time, it becomes harder and harder to control it. And that's because you're fighting against hard arteries and you're fighting against age-related damage and hypertension-related damage to these vessels in the kidneys, in the brain. And even if I got someone's pressure down lower, they might feel worse. So there are a certain population of people that you will never be able to fix. I have a couple in my clinic that frustrate me to no end. But what you can do is have someone else look at it. And the reason is it might be that the combination of medications that you're on or someone is on is just not effective. And so he may need a new combination of medications. And this is the part that's a little frustrating for patients is trying to get the right one and the right ones. But even under best medical management, some people just aren't treatable to a normal number. Now, maybe you could get you down to a number that takes away the risk of stroke as much. You know, what they did prove is if you drop your pressure by 20, no matter what the top number is, you're going to half your risk of stroke, okay? And so if you're 180 all the time and I get you to 160, you're a lot better off, okay? You're not normal. You never will be normal. That's what I tell a lot of patients. Okay, you never will be normal. See, he's still laughing. I like that. Maybe a different look at the right new combination. There's also something. I'll say one more thing. I know you guys probably want me to shut up. It sometimes matters not only if your blood pressure is low or lower or normal, but when is it lower. And what you want is a lower blood pressure at night. And you want your blood pressure to drop at night because you want your body to rest. There's a thing called dipping, and you want to dip. All right? So, anyway. Some people are dipping their head right now. Okay. Ready to go? Anything else, Deanna? Okay, she has more.
Again, thank you all for coming. We are glad you're here today. And if you take away one thing, what is that? He said it a long time ago. Don't just be aware, do something. So hopefully we have increased your awareness today about high blood pressure and some steps that you can take to help correct it or at least get to your normal. It may not be normal, but at least it's your normal. So we hope you've been informed. We are available through our Hypertension Clinic, through our website. You can ask us questions. We have Facebook. If you haven't gone out and liked us, we have 2 pages, NEA Baptist and NEA Baptist Clinic. And our websites are the same. You can go find us because we've got a lot going on. Daryl mentioned the construction and the move that's coming up. We're excited and we want to inform you. Everything's going to shift when we move on that day, and we want to make sure that you know that that's going on. We don't want you to have high blood pressure because you don't know where your doctors are. Family practice doctors will stay in their current locations, which we hope is very convenient for you. And the hospital will be moving, but it's going to be easy to get to and easy to park and to come in, and we'll welcome you there. If you need anything in the meantime, feel free to call us, and otherwise we'll see you September. We have a talk coming up on cancer. Thank you all for coming today. And one last thing, we'll be drawing for the door prizes. If you filled out your tickets, we'll have 2 $50 gift cards that we'll be giving, but we'll notify you either by email or telephone call. Thank you.